Okay, you'll be relieved to know that I'm not going to stand and talk to you for an hour, as it says on the programme, about Think Digital. I'm going to put up some introductory slides, talk about some of the things that I've seen that are working really well, and then it's over to you to actually do some work, talking amongst yourselves and thinking up some of those innovative solutions, hopefully going to your Disney dreaming tree and thinking about what you can actually think of, how we could use them in a better way. So we need to think digitally. As I said earlier in the day, we are working with a cohort of children and families, parents who are digital natives. So this is our child that we're working with. They can probably use that laptop better than I can. Okay, and constantly, again, like Maria said, everybody walks around with a mobile phone. Is there anybody in this room that hasn't got a phone with them? No, I thought not. Okay, so we need to utilise, and they're just very basic tools. Again, we need to think about social media, what apps are out there. There's an awful lot of things we can do. And it's all supposed to be really clear, and this was brought up at the last digital leaders meeting that I went to around the maternity agenda, and I thought it was a really good phrase, that there's sometimes a bit of nervousness about technology, that's going to remove people's jobs, and suddenly we're going to have robots instead of midwives and whatever. Well, that just is never going to happen. We know there aren't enough of us out there, and we need to use the digital technologies that are out there to enhance, not replace humanity. They are never going to replace the human things that need to be done to deliver care, but they can replace some of the things that can be sometimes more efficiently and accurately done by a machine, potentially. So why do we need to embrace digital and technology? It can be extremely efficient and extremely effective. We use it every day in everything that we do. It's convenient for families. Okay, it's much easier to receive a text message than to wait for the post. We heard earlier this morning with the example of Dr. Chris Gardner, who reviewed a film of a child that had noisy breathing. Instead of that family coming up with 4 children from Rosendale to hospital for hospital appointments, we should be doing more of that. It's very convenient. I can't remember why I put spread. Oh, spread so that we can get messages out more obviously, more clearly. One of the things we're looking at working, I know we haven't used it a lot today in terms of Slido, but the Slido tool you can use on a much far broader reach. So in terms of engaging, which again we've just heard with Maria in terms of how important it is to engage with all your stakeholders, there is an opportunity through tools like Slido that if I wanted to talk to or ask a question of the children's workforce, if there was a means of me to get a message to you all and say, could you go onto Slido in the next 48 hours, put in #136 and answer 4 questions for me. You can answer them in the bath. You can answer them wherever the hell you like. Just 4 quick questions on your phone, and that would give us a whole ICS level, potentially, an almost instant, within 48 hours, answers to some questions that we might want to ask you about. Again, we don't need to get you into a room to ask you 4 questions. There are lots of ways in which we can do it. Workforce shortages, obviously, that's the theme throughout today in terms of why we're looking to work differently. It can avoid attendances and admissions. Again, that example of Dr. Gardner. He says that if we could find a commissioning mechanism to allow him to work in that way for about 1 PA a week, he reckons he could avoid up to 30% of outpatient attendances by being able to see patients through a Skype link, through a video, through a phone call, whatever it might be. It can be more accurate and avoid human error. If there are certain things that if you can put rules around it, a machine can do it. It will avoid transfers of information. However many times we copy things from one thing to another puts in the risk of inaccuracy. So it can be far more accurate than we can. Okay, I've just talked about Slido, and again, a couple of sort of questions. Well, I've asked you all if you have a mobile phone. How many of you have a work mobile phone provided through work? About a third. How many of you have access to a computer at work? Most of you? All of you? Who has a work tablet, iPad, mobile device? About a third. Do you have a digital lead in your directorate? Do you have a person in your work area, in your team, that has a lead for digital technology, for innovation? 5 or 6. Okay, one of the most recent things, we've just done a national assessment in terms of digital maturity around maternity services. And one of the key themes that comes through is that people that are more further forward in the whole digital agenda, our maternity services have got digital leadership within them. So I've actually appointed digital midwives, and that's not a robot, that's a midwife that's got an interest in digital. So it is important to find those people, and there will be people in your areas that love that stuff and would love to get involved. And I think, is there anybody in here that considers themselves a digital native? No, we're all migrants. Okay, I thought so. But the other thing to remember when you're talking about digital things is that if you're talking to typically a boardroom full of people or your executive teams and things, you will also be talking to a room full of migrants. Okay, so sometimes it's harder for them to grab the opportunities and things that a digital native might bring or might want us to do. So just a few examples. I think, unfortunately, the majority of us are still working in the top left corner with reams and reams and reams and reams of paperwork. Okay, we all have an ambition to get to here when we're walking around with our tablets and have all our patient records in one place and they can all talk to each other and be interoperable and everything else that we want them to be. But I think we're somewhere off there. But obviously, I don't need to go into the efficiencies that would bring in terms of getting people's records together, patients having their own records. I went to East Lancs Hospital Trust the other week, and I did actually stop a lady and ask if I could take a picture, because I wanted it to hopefully at some point get into the archives of history for the NHS, the amount of people that are walking up and down corridors with trolleys full of notes. That is just ridiculous, absolutely ridiculous. But we're still there, and I know we're there in all our trusts. Remote monitoring. Okay, lots of brilliant examples of remote monitoring. Again, I'm sorry to refer back to East Lancashire, but because it's my home trust, as you might say, and again, they're completely blown away the other week by the amounts and the sophistication of the remote monitoring that's now being used around paediatric diabetes. All the children and young people walking around with their monitors. The paediatrician can bring up on the screen at any one time all those children, any of those children, what their blood sugars are, what they had for breakfast, the whole lot. Brilliant. What we haven't quite yet sussed is how we translate that through transition to adult care, but that needs to be worked on. But there's lots of examples. I'm sure we can do more in terms of remote monitoring. I think really we need to get to a point that we get to the end of a clinic and actually sit just for a few minutes, if you run clinics, for a few minutes and think, how many of those children that I've just brought into clinic, that I've had to come on 3 buses, whatever they've had to do to get there, how many of those children have you physically had to touch? Because if you don't need to touch a child, they do not need to be in the same room as you. They can be on the telly, they can be on a Skype, they can be somebody else supporting them somewhere else in the distance. If you've got a remote clinic, there's no reason for that family potentially to come to the hospital. They could sit in their GP practice with the practice nurse on the telly while they talk to the consultant back in wherever they might be. We need to think differently. Okay, so just keep that. How many people do you actually have to touch? Some of them, I'm sure, could get investigations done more locally, and I'll come on to that in a minute. So remote monitoring, I know it's brilliant and it's being used really actively in some disciplines, in some specialties. Are there others that we could do that more creatively? I don't know, how many of you are familiar with the Children's E-Hospital? 1, 2, 3, 4, that's only because I've told you. Okay, so the Children's E-Hospital is worth looking up. It's absolutely a fantastic online resource being created by an amazing man called Dr. Tim Uby, who is a consultant paediatrician in the North East, who got extremely frustrated about, he tells it exactly like I've just said, that about one family that came to clinic that actually had struggled through 3 buses with a buggy and a pram and a whatever else. And really, he thought about it after and said that they just didn't need to be there. There was no reason for them to be in clinic. So he's created the Children's E-Hospital. It's a fantastic online resource that can be used by clinicians, by families. As an online resource, it's got masses of information in terms of information on minor illnesses, on what to do in certain areas, a whole load of video clips on there, so not just text saying how to deal with various things, but video clips of how to do it. So this is what it's all CQC assured, etc. As a site, he's got CQC coverage in terms of that. That hasn't come out particularly well. So this is one of his pages for children or parents. So you go on to the bleeding child, the choking infant, burns, seizures, head injury, with all sorts. There's pages and pages of it. It's really useful to go on to. But he also does a couple of other things. He also runs, and I think with what I said before, he runs online consultation service. So at the moment he runs this privately, but there are things that we can learn from this to do in the NHS, I'm sure. At the moment, as a parent, if I lived in Devon, I could go online tonight and book an appointment for my child with Dr. Tim Uby. I go onto his calendar, I see when he's available, and I book an appointment. Within minutes, I will receive a booking form from him, which I detail all my child's history on, why I want him to speak to him, what's the issue with my child, and I send that back to him. If, when he reviews that, he thinks he needs to have any further investigations done or anything, he will send one of his team, his network of phlebotomists around the country, to visit me in my house in Devon and take my child's bloods, and send them to the labs that he commissions in London, who will send him the results by the time he picks up the phone and has a conversation with me later that week, a Skype consultation. By the time I've had that Skype consultation, 20 minutes after that consultation, he will have sent details of that to my local consultant, to my GP, to anybody else that I want to have that information around the additional advice that he's given. Now, people are using that for all sorts of reasons, and it is a private run-based thing, but why can't we do that in some ways, sometimes, and run our clinics differently? In talking with Tim, he says for some of the stuff he does, 60% of the diagnosis or things is based on history, and actually you had a much better history giving parents or carers a chance to actually sit and write that history out and send it to you. The often you get time to do in an outpatient appointment. Sometimes you have to rush that history, and there's some really useful things in there to inform your diagnosis and ongoing treatment. He's also developed the Hot Pod, which is a home monitoring kit. It's available on Amazon at £99.60. It's not expensive. It allows a family to monitor their child, having been shown how to use it. It monitors their heart rate, oxygen levels, temperature, apps to measure the breathing rate, perfusion, and mental state. It is allowed, in the areas that it's being used now, it has significantly allowed children to go home earlier from the ward and avoided people bouncing back in because they feel their child's still not well. It's been used by people that are maybe common attenders to give them assurance that they don't need to bring their child to ED or up to the ward. It comes with charts to actually show you for your child's age and weight what the normal parameters are. So obviously it needs education for the parents, but it's a fantastic little tool. And if we look at, £99.60, and that's just buying it as a one-off. But in terms of avoiding a hospital admission or a child sitting in a bed, it's an absolute bargain, and it enables families to see, what they could be monitoring better at home. And I'm not getting paid for selling hot pods, I promise. It's just an example of what is available. So we can use digital for a whole range of things, like Christian said. So we can use it, I know some places are already using it for some of their diagnostics, so outsourcing your radiology, scanning and things like that. Training and education. Okay, today we've brought you all together in this room, which has been great. We've had some really good discussion. We are slightly utilising technology, so all our speakers have been filmed today. All these presentations and the discussion that we've had will go online, will be accessed, hopefully, by a whole range of other clinicians that haven't been able to be in the room today. So again, there's ways of doing things. We could have had international speakers on that screen, Skyping in from wherever, from Boston, from Australia, but you can get international best practice without having to put anybody on a plane. Running webinars, how frustrating is it now when still everything means you have to go to London? The most ridiculous thing, I'm a member of the digital leadership group around maternity services, they won't do it as a webinar, and it's for digital leaders. You have to go to London. ridiculous. Sitting with, I've called it. If you're a clinician that works somewhere quite remote or whatever, and you feel you're not getting good experience in a certain way, there's no reason why you can't ask one of your specialist colleagues if you can sit with them in clinic one day. That doesn't mean you have to go and sit with them. That means you can have a screen and you can watch their clinic and you can interact with them between patients. You don't need to go. Okay, there's so many things you do not need to go. Clinics, obviously, allowing patients to self-book. When will we get to that? Skype clinics, specialist clinics, like I've said there. One example I keep saying is that, we've got children up in Barrow who might need a specialist opinion from somebody in Alderhay. Okay, that specialist from Alderhay does not need to travel to Barrow. They could sit in Barrow with a Band 5 nurse who could do any close observations that were needed, tell the consultant sitting in Alderhay, this is what's going on, this is what's happening. Avoid the travel, much more efficient, get a full clinic out of that consultant and nobody's left their home base. So, having gambled through that, what I'd like you to do on your tables, and there is some flip chart paper on your tables for all your ideas, is to think about where the digital opportunities are in your work area. Okay. And which of them, I want each table to come up with 3 examples at the end of the time. So which of them would have the greatest impact on, one example, which would have the greatest impact on increasing your efficiency? So what do you think that you're currently doing that's bonkers, that could really be done better by a machine, by technology, by doing things differently? Okay, what could have the greatest impact on enhancing patient and family experience? So what would families like? And then thirdly, which would have the greatest impact on improving safety and patient outcomes. So if you can have some general discussion around your pathways, the places you work, it'd be great if you've got some really good examples already to share that's already being done in certain areas. Where are your frustrations? What could we help with? Quite happy to take this back to the ICS digital team and see which of them we can actually put into practice if there's some really great ideas.